Hello, I'm Doug Lake. I'm a radiologist at the McFarland Clinic and Mary Greeley Medical Center in Ames, Iowa. I'm a part-time radiologist at Stanford. I've been asked to give this talk about demystifying breast cancer screening. This is important information that I'm proud to share with others. I've compiled this information from a number of different sources, as we'll talk about as we go through the talk. First of all, I don't have any pertinent disclosures that affect what I'm talking about today. What do I mean by demystify? This is Main Street in Ames, Iowa, on a spring morning in 2019. It was just foggy, misty. It was hard to tell where you were. You knew where you were. You knew you were on Main Street, but things were more difficult to see. It was just hazy. And that's where I feel like we are with breast screening. There's a lot of talk about starting at age 40 or age 45 or age 50, depending on the strategy. There's talk about should we screen every year or every other year? What are these other things about breast density? What is automated screening breast ultrasound? What is abbreviated breast MRI? What role does diagnostic breast MRI have? There are so many bits of information that are new in the last 5 or 10 years that I wanted to try to clear the air and talk about this. So I get asked a lot of questions, and so I want to start out with some breast cancer background, then talk about what's the difference between a screening mammogram and a diagnostic mammogram. What is breast density? What are false positives? What is overdiagnosis? And what is overtreatment, which are common concerns that folks raise about screening for breast cancer. So first, some facts. These are simply intended to be factual. They're not intended to be scary or worrisome or anything. These are just the facts from the American Cancer Society. In 2019, breast cancer is the most common cancer in women after skin cancers. There'll be more than 330,000 new cases of breast cancer diagnosed in 2019. But the best number is at the bottom of this slide, that almost 3.5 million women in the United States are living with breast cancer because we're diagnosing it earlier and we're able to treat it better than we ever have. I strongly believe that you'll learn more, that I've learned more and others will learn more from lectures if you have to actively participate. Since this is something that's on the internet, I can't point at people and I can't ask questions, but in your mind I want you to commit to an answer to some of these, and I think you'll learn more from it. The first one is mammography has reduced breast cancer deaths. Simply true or false? This is a common question that we're asked. This is a very nice slide loaned to me by the American Cancer Society, or the American College of Radiology and the Society of Breast Imaging. In it depicts that we began screening mammography on a widespread basis in the late 1980s. And since that time, breast cancer deaths have been driven down year after year. There's a number of things that contribute to this, but we firmly believe that screening mammography and diagnosing breast cancer early, detecting it early, treating it early, helps drive down mortality because women present with earlier disease without late-stage disease. Now, another question. Something statistically magical happens when a woman turns 40 that puts her at increased risk of breast cancer. Is this true or false? Is there something magical that happens at age 40, at age 45, or at age 50? This graph is very important. It shows the incidence of breast cancer in the United States in, I believe this was 2017 or 2018. And as you can see from the graph, the bottom of the graph we have women by age 31 to 35, 35 to 39, 40 to 49, and so on as they go up into their 70s and 80s and then 85 and above. On the y-axis of the graph is the incidence of breast cancer, the number of new cases. Beginning at age 40, there is a stepwise steady increase in the incidence of breast cancer, with a peak incidence at about the age of 80. And so you can tell from this data that screening should begin at age 40 to maximally reduce the deaths from breast cancer. Now, what is a screening mammogram and what is a diagnostic mammogram? When women present for simply screening and have no complaints and no issues, that is a screening mammogram. A diagnostic mammogram is performed in women who have some lump, some redness, some pain, nipple discharge. There can be a variety of different concerns that lead a woman to end up having a diagnostic mammogram, which often is accompanied by an ultrasound as well. If a woman is recalled for additional imaging, she probably has cancer. This is the concern that I hear about a lot as a breast imager and as a radiologist. Is this true or false? If you get called back, you probably have cancer, right? This is a wonderful, wonderful diagram that shows what happens for most women when they get recalled for additional imaging. Out of 100 women who have a screening mammogram, 90 will not be called back. Okay, so first of all, in my practice it's less than this, but overall nationwide, only about 10% are called back. Of those 10 women who are called back out of 100, 6 will be told they don't have anything to worry about and come back either in a year or sometimes in 6 months. 2 will be told to come back in 6 months for some form of additional imaging. 2 commonly undergo a biopsy. So most of the women who are recalled do not have breast cancer and do not have anything to worry about besides additional imaging. Now, when should an average risk woman begin screening mammography? This is a foundational, critical question. And more importantly, not just when, but why? Is it age 40? Is it age 45? Is it age 50? Now, we believe, there's a variety of organizations that believe that, and strongly show it in the evidence, that age 40 is the age when the average risk woman should begin screening mammography to maximally reduce her risk of breast cancer. And this is because 1 in 6 breast cancers are found in women between the ages of 40 and 49. And about 1/3 of the years of life lost to breast cancer are from women in their 40s. This is another slide and information loaned to me by the American College of Radiology and Society of Breast Imaging. This shows the distribution of years of life lost due to breast cancer death by age at the time of diagnosis. And as you can see, 2 of the highest bars, 2 of the highest incidents of death occur in the ages of 40 to 45 and 45 to 49 years of age. So that's a critical area of the population that we really do need to be screening. In some societies they say that it can be optional screening, but you need to know that this is one of the highest incidents of death if screening does not occur. Another important question. Dense breast tissue is a stronger predictor for breast cancer than family history. We hear a lot, and over the last 20 years we've heard so much about family history and the genetic risks of breast cancer. Does dense breast tissue really make that much of a difference? And the answer is yes. It is a greater risk. We're going to talk about breast density a little bit more. Looking at the pictures of the breast in the lower part of the slide, we categorize breast density into 4 broad categories: fatty, scattered fibroglandular densities, heterogeneously dense, or extremely dense. Beginning on the right side of the slide, there is a relatively fatty breast. On the other side of the slide, there's a lot of white, dense material. It's fibroglandular tissue in the breast. Breast cancer presents as a small white dot typically, or it can present as calcifications. It can be more difficult to identify a mass or an asymmetry or calcifications in the very dense breast. So masking is one of the issues, and that is one of the things that we believe also contributes to the problems in finding breast cancer in very dense breasts. The other issue is that we're learning that there is just simply an increased risk in these women for a reason that we haven't ascertained at this time. We believe it may be related to hormonal stimulation, but for now it's important to know that if you have category C or category D breast density, you should think about supplemental screening. And what is supplemental screening? In my practice and in other practices, that may be automated screening breast ultrasound, which is where both breasts are imaged with ultrasound to try to detect additional cancers. Abbreviated screening breast MRI is another technique that can be utilized. It's a breast MRI that's very quick. It takes about 8 to 10 minutes for most women, and it will detect additional cancers that mammography can't see. In our practice, we utilize the Tyrer-Cuzick model. So every woman who comes into our practice, we calculate what her lifetime risk of breast cancer is. Any women with a greater than 20% lifetime risk should consider undergoing diagnostic breast MRI. And currently, the National Comprehensive Cancer Network recommends diagnostic breast MRI yearly for women who have a greater than 20% risk of breast cancer. What is false positive? This is one of the criticisms that's laid to mammography. False positives are women who come back for additional screening and are not found to have anything that are abnormal. And this happens. It's part of a screening process where we try to find women with breast cancer, and there will be some who are called back. In our practice, only about 4.3% of women in 2018 were called back for additional imaging. And as you can see from the rest of the slide, most of these women did not have breast cancer, as we illustrated previously. What is overdiagnosis? Overdiagnosis is detecting a breast cancer or some disease that would have not led to any clinical symptoms. On an individual basis, though, we have a very hard time discerning which cancers are going to cause problems and which cancers may not cause problems, because we can't predict the future and we can't predict which cancers will cause problems and which won't. We estimate currently that between 1 and 10% of all breast cancers are a result of overdiagnosis. But the alternative, the other side of the coin, is that underdiagnosis is not an ideal situation either. So we try to find all the breast cancers that we can, and maybe someday in the future we'll be able to tell with better information whether we're finding a cancer that wouldn't have caused a problem. Now, breast cancer represents a single disease with a single best way to treat it. True or false? This answer is false. Breast cancer is an umbrella term for a variety of different diseases that can occur in the breast. And overtreatment is one of the issues that we are criticized for, that we sometimes treat breast cancers that wouldn't have caused problems long term. And similar to the last issue of overdiagnosis, it's very difficult on an individual basis which cancers were overtreated and which ones were not. So, in summary from this quick presentation, I recommend annual screening mammography for women age 40 until they would no longer benefit from screening, which typically is less than 10 years of lifespan, or if a woman decides I would not do anything about finding or detecting or treating my breast cancer. Recall from screening does not equal cancer, and it's important to keep in mind. Women should know their breast density and what options exist for supplemental or additional screening. And please know that false positives, overdiagnosis, and overtreatment are potential issues with screening mammography, but at this time we don't have enough information on an individual basis to make intelligent decisions about management. Thank you for your time, and I welcome you to follow me on Twitter.